All right. So trauma-focused psychotherapies should be considered first-line treatments for children and adolescents with PTSD, and I'll now spend just a few minutes kind of looking at some of those data, although I understand that you're primarily interested in the psychopharmacologic data. So CBT is supported by Category 1B evidence, probably now approaching 1A evidence. We have some meta-analyses. It's been found to be superior to some forms of child-centered therapy as well as supportive psychotherapy. There's also some evidence for individual psychodynamic, which is found to be superior to group psychotherapy, and psychodynamic psychotherapy has been found in one study to be superior to behavioral reinforcement therapy. I also included a slide and a reprint a little bit later looking at prolonged exposure therapy in kids with PTSD, which compared to psychodynamic psychotherapy in that population. Here's kind of the standard mnemonic for the components of trauma-focused CBT. I think that it includes a lot of bread and butter CBT elements. Now, we've already touched upon multiple times the issue of dissemination and training. One of the nice things with TFCBT is that there's a starter training module that's available through this website at the Medical University of South Carolina, which over a series of hours takes you through some patient videos as well as the standard techniques, and just is really a great site in terms of disseminating trauma-focused CBT. The next form of psychotherapy which has received a bit of attention is EMDR. One of the things with EMDR in kids is that when the practice parameters were written by ACAP, there was a sense that this was somewhat different from EMDR that's typically used in adults, in that it included a lot of CBT type interventions. And thus in the practice parameters, it was actually lumped with CBT rather than as a distinct entity, although it's shown benefit in many of these studies. There's the article that I'd mentioned a little bit earlier, looking at the efficacy of both dynamic psychotherapy as well as prolonged exposure therapy. Some methodologic issues here in terms of contact hours, which were markedly greater for the kids receiving prolonged exposure therapy versus dynamic. No significant difference at 6 months. There was a significant difference long term in terms of number of kids losing the PTSD diagnosis. So I'd like to now jump to my proposed treatment algorithm for PTSD. And we'll talk about this in terms of the levels of evidence that we've been using for the purposes of the guidelines a little bit later. Certainly TFCBT or some other form of trauma-focused psychotherapy is recommended as first-line intervention. In those kids who do not respond or who have a partial response, again here at the level 4 level of evidence, I think that there is reasonable evidence for antiadrenergics, antiepileptics, as well as some of the second-generation antipsychotics. I think the main difference among these agents which should guide us clinically is probably more so related to side effect profile and tolerability based on our clinical experience rather than relative differences in efficacy. If there is not a response to one of these agents, I would argue that it's not unreasonable to consider augmenting or switching back with another of these agents. And if there is improvement, one would argue for continuation of that treatment. However, with the caveat that we should always be reassessing the patient for psychotherapy and that we should reevaluate medication need every perhaps 3 to 6 months. That's something maybe that we can talk about as we put together the guidelines. All right. Potential red flags, again, certainly a point that's very open for discussion. I thought second-generation antipsychotic use, although, again, there is some evidence for that. I would say maybe if it is being used as a first-line intervention or if some of these other psychopharmacologic interventions are being used first-line. Benzodiazepine use, there's no evidence for benzodiazepines in adults and absolutely none in kids with PTSD. And we now have a number of placebo-controlled trials in adults with PTSD with clonazepam as well as alprazolam. And then I would say also the lack of referral to psychotherapy might be another red flag. Although, again, I recognize the point that you've raised, which is access. In terms of comorbidity, I wanted to go through this rather quickly in the next 6 minutes or so. There are a number of comorbid conditions encountered when seeing these kids with PTSD, as everyone knows here in this room. So I think that this does probably raise the possibility of specific interventions when looking at the kids with comorbidity. And here you see that addressed in the practice parameters from the American Academy. Certainly, one of the things that's important in looking at these kids with comorbid conditions is this true comorbidity or is this syndromic overlap between the two conditions? Certainly, we know in looking at the first example, depression and PTSD, there are a number of symptoms including depressed mood, disturbed sleep, difficulty with concentration, psychomotor agitation, thoughts of death and foreshortened future, which syndromically overlap between the two conditions. And I think that's really what requires the most work on our part before deciding on a specific treatment for the comorbid condition. If we do have the kiddo with true MDD and comorbid PTSD, I would argue that something along the lines of this algorithm might be reasonable. Certainly, we'd want to make sure that diagnosis is confirmed for both disorders. And we would also want to try to understand the manner in which the two disorders occur relative to one another. Did the depression only start after the PTSD or following traumatization? If PTSD is more severe, it would be reasonable to begin trauma-focused psychotherapy, as many of the studies have suggested that there is benefit in terms of co-occurring depressive symptoms associated with this therapy. If depression is more severe, I would argue that an evidence-based psychotherapy for depression or pharmacotherapy be tried, and then you see here the various continuation algorithms or lines here. All right, in terms of the psychopharmacologic treatment of PTSD plus bipolar disorder, I realize that a number of patients with bipolar disorder, both in the adult literature and in the child literature, do have comorbid PTSD as well as other comorbid anxiety disorders. Again, we'd want to make sure that this is not just syndromic overlap between the two conditions, but rather true comorbidity. Just as an aside, recognizing the fact that traumatization is incredibly common in folks with bipolar disorder, even in those with first episode bipolar disorder. These are some of our data from Melissa Del Bello's first episode mania study, in which I looked at traumatization and the effects on outcome longitudinally. And what we found is only about 1/3 of these patients had never been exposed to any significant trauma. So looking now towards an algorithm, again, we would want to make sure that the diagnosis is confirmed for both disorders. We'd want to understand and clarify the manner in which the two disorders occur relative to one another. We would want to do two things. Number one would be mood stabilization and trauma-focused psychotherapy. If there are residual symptoms, I would possibly consider an SSRI, although again recognizing the fact that SSRIs are going to be very poorly tolerated in these kids with bipolar disorder. If there is improvement, but residual PTSD symptoms, I would want to consider some of these other psychopharmacologic interventions that I'd mentioned in the PTSD algorithm. The antiadrenergics, as well as kind of the mood stabilizers and antipsychotics.